presenting Home in Time for Tea.
Hi, good afternoon, everybody. Hopefully you can hear me. My name's Anna Winfield. I'm a geriatrician at Leeds Teaching Hospitals, and this piece of work was conducted as part of a team effort. Please progress on to the next slide. Thank you very much. So I'm going to talk to you this afternoon about the work we did as part of the project called the Discharge Collaborative. And this started as a consequence of a couple of things. The first thing being dissatisfaction and poor survey responses from patients about their experience of discharge. Lots of concerns from patients being told they could go home first thing in the morning, but not actually leaving the hospital until much later in the day, and in some cases, unfortunately, into the night. Leading to readmissions. And the second thing being, as part of Leeds Teaching Hospitals is one of the biggest teaching hospitals in the country. We receive lots of patients through our emergency departments every day, and a problem being overcrowding in the emergency departments because patients backing up because they're not able to actually be admitted onto the ward because there's patients on there who haven't yet been discharged. So it was to try and improve flow throughout the hospital, and our aim was to discharge 70% of patients by 3 in 12 months. And this was done as part of a team, we created a faculty of interested people, multidisciplinary frontline teams, including a patient partner, to work on this problem. And we tasked wards with the idea of saying use PDSA cycles to try and work on this problem as much as they can and trial ideas that they think will work. And that's exactly what they did. So we used tools such as case note review to review late discharges, work out common themes and tackle those head on. And if you move on to the next slide, we'll talk a bit more about that. We also use tools like Pareto analysis to work out which is the biggest ward perhaps that's discharging the most patients late that we could work on first. And interventions that we used were an EDAN board, thank you. Looks like it just cut me off there. Can you hear me again?
Yes, I wasn't sure if I'd frozen or everybody else had frozen or just you'd frozen. Can everybody else hear?
I can hear you. Yeah, I can hear you.
I don't know if the whole thing just crashed for a moment there, but I'll just take 30 seconds. I'll do the last 30 seconds very quickly.
That is perfect. That's exactly the time that we're on.
So it's basically interventions that were developed, such as recording who needs a discharge summary on a board every day, simple things like having a golden patient. And this resulted in step improvement of 12%, resulting in about 49% of patients going home by 3, as can be seen on the run chart. And since this work has continued, we've actually had a second improvement. Lots of lessons to be learned. It's a massive project that still continues, and it's a complex system. Lots of approaches are needed. There's not a simple fix, but the data has been absolutely crucial to drive the change, because people can focus, as we can see in the pie chart, what's the biggest problem? Let's tackle that. And by using that approach as a team, it's really helped. So, thank you for listening, and I'm happy to answer any questions.
Brilliant. I'll pass you over to Vardeep then, and I'll start your 3 minutes now.
Lovely, thanks, Anna. Really impressive project, and really like the use of the run chart. And actually, a couple of things that you've said that are of real interest. The first was you said the team empowered people to use PDSA cycles to make those improvements, and I just wanted to ask: how did you? Do people already have a good knowledge of QI methodology?
Well, it was a bit of a mixed bag. I'd say there were some wards that were ready to more or less with minimal support go off and try ideas and come back to our faculty meetings with what they've tested and tell us how that's gone. But for other areas, it required quite a lot of support. So we had to do a bit of training on the ward training with some of the teams, and quite a lot of well, we can learn from this person, and maybe somebody stronger, perhaps a doctor who's done a QI project before, could help some of the nurses. So it required a bit of a combination of work. And I'd say the teams that have been most successful are perhaps the ones that have had a bit of a combination of some support from our core team in terms of the faculty, but also had a bit of knowledge about QI. But in Leeds, we've directed people to QI training that I actually lead in the trust anyway. So anyone that was a bit underconfident, we'd say, well, go to the training and then see how you get on. So yeah, I'd say a mixed approach.
Yeah, but really, really helpful to do it on something live rather than theoretical.
Definitely.
And with the data, because that was another thing that was really interesting to hear, that you were using the data to sort of keep that motivation up of making those improvements. So how were you sharing that, across teams?
Yeah, that's a good question. So there's room for improvement there, of course. So we have our intranet where we have a dashboard, a quality improvement dashboard, and one of our measures is obviously discharge by 3. So that's on the dashboard. But having a dashboard is one thing, but actually getting people to use it is another. So we measure the clicks on that, which obviously have increased over time. But we also share the data every meeting in our faculty meetings. So that covers quite a few people, but it definitely doesn't scratch the surface. And I think the main thing that's been useful is any ward that's had a statistically significant improvement in discharges by 3, we'd go and give them a certificate and talk through their data. And then if by doing that it's been sort of a number of years now, that sort of helped get the message through. Because if a ward is getting a certificate for doing well, they then become very interested in the data. So that helps sort of hook them in.
Yeah, really clever. That's a really smart way of doing it, and probably is going to be the most impactful, isn't it? Incentivizing in a very sort of localized way of improvements that they're making. Yeah, that's a great idea. Thank you. Thanks, Anna.
Thanks for listening. Cheers.
Thank you. All right, Anna, if you'd like to mute.